Hello everyone and good afternoon. It's an honor to be here today remotely to speak to all of you, and I would like to thank everyone who organized this event and made it possible for so many people to speak here today and tomorrow. I'm Sabrina Engel, biotechnologist, and I'm working with PETA Germany on the issue of animal experimentation. If you have any questions after my presentation, please don't hesitate to contact me. Biomedical education is one of the fields that is currently undergoing massive global changes with the potential to spare countless animals' lives and better prepare the physicians of tomorrow. And this area is the subject of my lecture today. Hands-on skills training in biomedical education has traditionally relied on the use of many millions live vertebrate animals each year worldwide, more than 9 million in the US alone. The experiments range from performing minor surgical manipulations and pharmacological interventions to managing major traumatic gunshot wounds, burn injuries, and dismemberments. The following slides will take you on a journey through the history of several different areas of medical training. Based on a confluence of different factors, including growing concern about animal use in experiments, technological advances in the medical simulation fields, heightened financial constraints of institutions, and educators' need for better teaching tools, a paradigm shift has taken place that has seen a significant reduction or even the full replacement of animal use in several training programs. The information I will present you is often US-based, but it can be seen as an inspiration, invitation, and call for modernization worldwide. Medical students in the US have historically participated in classroom animal laboratories. In physiology labs, students were typically instructed to inject live animals, for example dogs, with drugs while measuring physiological responses such as blood pressure or heart rate. Sometimes students even cut open animal chests to massage their hearts. Afterwards, the animals were killed. In surgical labs, medical students practiced incisions, organ identification and removal, suturing, and other basic surgical procedures on live animals. The Harvard University fully ended its use of animals for the undergraduate medical curricula in the 90s. Instead, instructors at Harvard now use academically superior, widely available, and more cost-effective human patient simulators, computer-assisted learning software, and virtual reality programs. These methods, unlike experiments on animals, accurately model human anatomy and physiology, create immersive scenarios that mimic real-world medical cases, allow students the ability to repeat medical procedures until proficiency, improve the confidence of doctors in transferring learned skills to clinical practice, and provide educators with real-time and objective performance feedback. Fast forward more than 2 decades later to 2016, the last 2 remaining medical schools in the US ended their animal use, partly after a nearly 10-year campaign initiated by PCRM, which involved letters from physicians, public transport ads, petitions signed by more than 100,000 people, and doctor-led demonstrations. Since then, undergraduate medical education at all medical schools in the US has officially been animal-free, now relying instead of didactics, virtual reality, cadavers, computer software, high-fidelity patient simulators, and supervised clinical work. Worldwide, animal-free education is spreading. In 2011, Canadian medical schools completed the full transition to non-animal undergraduate medical student curricula, and in 2012, the Medical Council of India amended its regulations to require the use of computer-assisted learning software to fully replace animals for trainings in the Bachelor of Medicine and Bachelor of Surgery curricula. The Pharmacy Council of India and the Dental Council of India also directed an end to animal use for training purposes. Further, the University Grants Commission in India banned the use of animals for dissection and training purposes, sparing nearly 19 million animals per year who would otherwise have undergone massive, invasive and deadly procedures. These developments in India followed campaigns led by PETA India, other animal protection organizations, politicians and celebrities. Further, growing evidence shows that non-animal training methods teaches students anatomy, physiology and pharmacology as well as, and in most cases better than, animal dissection and experimentation. Another area that has seen great strides in the replacement of animal use is the Advanced Trauma Life Support Program, which was introduced in 1978 and has become the standard of care for the initial assessment and treatment of trauma patients. The course is now offered in 86 countries worldwide. Historically, the surgical skill station of the ATLS program was taught by having students each year practice invasive procedures such as chest tube insertion, venous cut down, and diagnostic peritoneal lavage on live dogs, pigs, sheep, and goats. However, since the turn of the last century, the efficiency, practicality and ethics of using animals for ATLS training has been brought into question due to a host of factors. There have been significant improvements in the technical accuracy and tactile realism of human simulation models. Animals are not able to properly simulate human emergent clinical conditions. Institutional education budgets have decreased, yet cost burdens associated with animal labs remain. The medical community is focusing more and more on improving patient safety and reducing clinical errors through simulation-based training. In 2001, the American College of Surgeons, which oversees the ATLS program, approved the use of alternative methods as full replacement to the use of animals for the first time. These include human cadavers and simulation systems such as the SynMan and the TraumaMan system. The TraumaMan system, for example, is an anatomically correct human torso with lifelike skin, tissue, internal organs and bones, as well as simulating bleeding when cut into and airway response. Studies have shown that TraumaMan performs as well as or better than animal use for both students and instructors. Today, more than 99% of ATLS training facilities in the United States and 100% in Canada now exclusively use TraumaMan and other approved non-animal training methods. Whilst the shift away from animal use to simulation in the US and Canada has made a big progress, a survey of 2017 found that numerous international ATLS officials from countries that use animals for this course expressed a desire to switch to animal simulation models, yet cited financial constraints as the primary transition barrier. To solve this issue, PETA established a collaborative donation program with the TraumaMan manufacturer Simulab and ATLS leaders in 23 countries to replace their use of animals with TraumaMan models. As a result, these 23 countries represent more than 1/3 of all 64 national ATLS programs surveyed outside of the US and Canada that now have fully replaced the use of animals for ATLS training due to PETA's donation of 124 TraumaMan models. To put this into perspective, prior to the TraumaMan donations, 38 of the countries confirmed using animals for ATLS training and only 18 countries confirmed using exclusively non-animal training methods. After the donations, just 12 of the countries continued to use animals, and 41 countries now use exclusively trauma men, sin men, or other non-animal training methods. Military medical training has also made big progress in replacing animal testing for decades now. The first published curtailing of the US military's use of dogs, cats, and primates in invasive wound experiments occurred in 1983. After publications from PETA, the US Department of Defense banned the use of dogs, cats, and non-human primates. However, the Department of Defense allowed for the use of pigs and goats that continues today in so-called live tissue training, a practice that thousands of physicians and veterans now oppose. During LTT, instructors attempt to mimic human combat injuries by inflicting damage in live pigs and goats, including gunshot wounds, limb fracture, burns, laceration, and bleedings, so that students can attempt to identify the injury and practice proper treatment procedures. But unlike using animals, amazingly realistic simulators faithfully replicate human anatomy and physiology and can replace live animal trauma exercises in full. Such simulators are the already mentioned Trauma Man System, Strategic Operations Catsuit, CAI Healthcare CESA, KFOR's Government Solutions Multiple Amputation Trauma Trainer, and lifelike military mannequins, among other models. Indeed, PETA and medical experts conducted a study published in the medical journal Military Medicine and found that 21 out of the then 28 NATO countries have reported they avoid animal use in their military medical training. Instead, they use human patient simulators and other non-animal training methods. Following decades of innovations in the medical simulation industry to create lifelike human trauma models, eyewitness investigations, numerous protests, complaints filed with government officials, and congressional inquiry, and decreasing public acceptance of the use of animals in experiments helped prompt several key policy changes regarding medical training in the military, and progress can be seen. In 2010, the US military launched a multi-million-dollar research program to investigate alternatives to using animals. Similar to the previously described areas of biomedical education, studies in the military field confirm that emergency medical procedures and traumatic injury management on human simulators are as proficient as those taught by using animals, and that both methods produce similar degrees of stress in trainees and can be more cost-effective than live animal tissue training. In 2011, the US Army ended cruel and archaic chemical casualty trainings with animals in which monkeys were poisoned with a drug overdose that makes them suffer from violent seizures in a crude demonstration of the effects of nerve agent exposure, and replaced its use of animals with trained actors, computer programs, and high-tech human patient simulators. In 2013, the US Army required all non-medical personnel and certain medical personnel to exclusively use human simulation training methods instead of LTT. 1 year later, 2014, NATO's Science and Technological Organization launched a task group to evaluate suitable non-animal training methods and noted that the use of animal in military medical training will have to be severely curtailed, if not completely eliminated. The same year, The US Coast Guard cuts its use of animals for LTT by more than half after meeting with PETA, and the Department of Defense directed all military service branches to cease using animals for 6 areas of medical education. And 3 years later, the authority made a historical decision by becoming the first branch of the US Armed Forces to fully end all use of animals for LTT in favor for human simulations. And in 2018, a US federal law was introduced which includes game-changing, first-of-its-kind restrictions that forces the Pentagon to focus on more effective, ethical and economical human simulation technology as the new gold standard of trauma training. Of course, there are more biomedical training programs in which animals are still abused as test subjects in procedures that can cause bleeding, swelling, pain, scarring, collapsed lungs, and even death to the animals, instead of higher quality non-animal methods being used. Only 2 more examples are the pediatric intubation training, where a full ban on the use of animals was achieved across the entire US Department of Defense, and thoracoscopy courses in a German hospital, which now are conducted with only animal-free methods after discussions with PETA. Whole body simulation or task trainer devices are frequently used as educational tools in place of animals. Implicit in the replacement of animal use is that the simulation-based methods have equal or better outcomes for the learners, and several studies confirm this point. There are 6 key advantages to using human simulation models instead of animals. First, high-fidelity simulators accurately model human patients. They can adapt to medications with changes in heart rate, blood pressure, and respiratory rate. They can demonstrate a number of pathophysiological disease states. They can teach surgical procedures that mimics the surgical anatomy and duplicates bleeding vessels. And they can also measure the reduction in time to perform the task as a measure of proficiency, record surgical errors, and be accompanied by real-time feedback and targeted practice. Second, simulators improve technical proficiency. In a randomized study looking at emergency procedures, researchers assigned subjects to either human simulator or live animal training labs, and the result demonstrated that trainees had significantly better acquisition of procedural skills when the simulators were used. Third, simulators improve patient and medical provider safety. All simulation training avoids the potential risk to the patient of medical trainee-induced complication. The first needle insertion, suture repair, or incision by a medical student can be done by using a simulator. Also, the use of simulation can prove to be safer for the medical student. Needle punctures can result in the transmission of diseases such as hepatitis or HIV, and therefore the avoidance of early needle punctures in infected patients allows the student to gain some proficiency using simulators and to avoid early risk to self-inflicted needle injury with a contaminated needle. Number 4, simulators foster development of higher order cognitive skills. One study examined the use of high-fidelity patient simulation on the types of learning that medical students report after a simulation-based clinical exercise. 94% of students rated the quality of the simulator sessions as excellent, and 46% felt that simulators are superior to other methods in teaching clinical decision-making and communication and teamwork. Number 5, students can benefit from immersive simulation-based training that mimics realistic clinical scenarios. Surgical equipment, anesthesia machines, gauze and gloves can bring the learner into an engaging, realistic and immersive clinical space. The level of engagement has been well described, and such levels of activation are crucial to learning and the promotion of key non-technical skills like effective communication, an organized approach, management of resources and people, and a maintenance of global awareness. And number 6, simulation shortens the medical trainee learning curve. A meta-analysis found that the majority of reports demonstrate the utility of simulation in providing faster learning with better retention of concepts over time. Almost all of the reviewed papers showed that simulation was at least as good as, if not better than, conventional teaching methods. Another study showed that simulation-based training accelerates or shortens the learning curve experienced by any beginner or trainee by allowing for ongoing coaching, evaluation, feedback, and correction through deliberate practice. The choice of which medical training modalities to use should be based on key metrics such as what methods improves provider knowledge, confidence, proficiency and accuracy. And for all of these criteria, studies confirm that providers trained via human simulation meet or exceed the standards set by those trained using live animals. There is a general lack of policy harmonization globally between countries and locally between labs regarding the use of animals in biomedical education. For instance, the United Kingdom prohibits surgical training on live animals, yet other countries still allow the use of animals for this purpose. The US Coast Guard has banned the use of animals in trauma training drills, yet other US military branches continue to allow this practice. 21 NATO nations, including Bulgaria and 17 other EU member states, have confirmed that they do not use any animals for military medical training. Yet 7 NATO nations, some of which are EU countries bound by the directive that requires the use of non-animal training methods whenever possible and whenever available, still continue to use animals for LTT. Also, many medical schools around the world continue to use animals in physiology and pharmacology training, among other disciplines, despite this practice having been abandoned by all undergraduate medical schools in the United States, Canada, and India. Concerted efforts should be made by institutional animal care and use committees to identify procedures, skills or concepts that are currently taught at certain facilities using simulation technology and advocate for their adoption by comparable training programs that are still using animals for these lessons. Furthermore, medical education bodies should publish position papers, position statements that reflect best practices for procedural competency, which, based on the medical literature, would include the replacement of animal use for biomedical skills training. For teaching similar medical concepts and skills, there should be no excuse for an animal suffering and dying in one institution and another institution avoiding animal use completely. Institutions have a responsibility to replace animal use when possible. Successes have already been achieved worldwide through public education, eyewitness investigations, campaigns, regulatory complaints, public protests, and media coverage, as well as partnerships with medical simulation companies to donate advanced simulation technology. And we must not stop until global biomedical education is animal-free. This is the future for the animals and for a better biomedical education. Thank you very much.